In the second part of cardiovascular disorders, we are going to focus on problems concerning the heart. First, we need to discuss the cardiac cycle. This represents the repeating pumping actions of the heart. The term systole refers to the contraction phase. Primarily, we refer to the ventricles, but the atria will also undergo a period of systole. Diastole refers to the relaxation phase, again referring to the ventricles, but the atria also undergo diastole. Some terms related to the cardiac cycle. End-diastolic volume refers to the volume in the ventricles at the end of their filling period. So this would be the total volume in the heart after the ventricles fill. Stroke volume refers to the volume of blood pumped from the ventricles in one contraction. And systolic volume refers to the blood remaining in the ventricle at the end of a contraction period. Not 100% of the blood is ejected, only a certain amount, and the part ejected is referred to as the ejection fraction. This is the percent of blood pumped from a filled ventricle. So if the end diastolic volume is 100 milliliters and the stroke volume is 70 milliliters, you can calculate the ejection fraction, and that would be 70 mils out of 100, or 70%. Our heart rate is under both nervous and hormonal control. And we're going to look at the conduction system, the nervous conduction system over the surface of the heart. Everything begins with the sinoatrial node. This is a group of specialized myocardial tissue that is found in the upper portion of the right atria. The SA node has the ability to excite itself. It is self-stimulating or self-exciting. The activity of the SA node is rhythmic, and it sets the heart rate. As a result, it is referred to as the pacemaker. The SA node is pre-programmed to self-stimulate or to fire on average between 80 and 100 times per minute. If the heart were not under any other control, this is how often our heart would beat 24/7, regardless of activity level. Once the SA node fires, it is going to send its signal on to the AV node. On its way, the stimulus will spread over the surface of the atria as it approaches that AV node. Also, as it approaches the AV node, the signal will slightly slow its progress. This will give the atria time to completely empty itself of its volume. The second group of tissue is the AV node. This is found in the floor of the right atrium, right where all four chambers come together. This is the only normal conduction pathway from the atria into the ventricles. Once the signal hits the AV node, the atria now contract and finish their contraction. From the AV node, the stimulus is spread into the AV bundle. This is found in the upper portion of the interventricular septum. This quickly branches, becoming the bundle branches. There are two of these, one that runs down each side of the interventricular septum, servicing both ventricles. From the bundle branches, the signal is sent into the Purkinje fibers. Their job is to distribute the impulse to all of the muscle fibers of the ventricle. So the Purkinje fibers come down around the apex and spread up over the surface of the ventricle, ensuring that the entire ventricle is depolarized and then ready to initiate a contraction. The term sinus rhythm refers to the cardiac rhythm that is initiated from the SA node. This is the normally functioning signal generation and conduction system over the surface of the heart. Sometimes people develop ectopic foci. These are abnormally functioning tissues, and in certain disease conditions, these can take over signal generation of the heart. We're going to focus primarily on heart disease. For death to be caused by heart failure, the ventricles must have failed to maintain blood circulation compatible with basic life processes. If heart failure is indirectly caused by some other disease, death will be attributed to that disorder. We're going to look at various terms associated with heart failure. The most common pathology leading to heart failure is ischemic heart disease. Acute versus chronic heart failure. Acute failure is if heart failure develops quickly. 35% who suffer acute heart failure will die from this. 65% survive, but the remaining heart function depends on the extent of the damage. Chronic heart failure develops over time. And what happens is over time, this condition will place an added burden on one's heart. Failure often occurs when the burden exceeds the ability of the heart and the circulatory system to adapt. Then the person may experience acute heart failure due to either 1, the natural progression of the disease, 2, failure of therapy, or 3, sudden and excessive cardiac demand. For example, this is often what causes a person to die of a heart attack in the wintertime when they are shoveling snow. This is an excessive cardiac demand on a heart that is failing. Right-sided versus left-sided heart failure. The common pattern in heart failure is for the left side to fail first. It makes sense since it has a much greater workload and is stressed to a greater extent compared to the right side. One may also see, associated with left-sided heart failure, pulmonary congestion and edema. Remember that the lungs empty into the left heart. So if the left heart is failing, the blood is going to back up into the lungs, and this can cause congestion. It will cause decreased perfusion of the kidneys due to a decreased cardiac output from the left side, and cerebral hypoxia for the same reason. Right-sided heart failure often follows left-sided failure, but it can occur first if the primary disease is a lung issue. When the lungs are failing, this puts added pressure on the right ventricle because there will now be an increased resistance of the lungs' vascular beds. This will result in signs and symptoms of congested heart failure. Low output versus high output heart failure. Low output is the most common. This is due to the heart not being able to meet the normal resting oxygen demands. This will result in impaired peripheral circulation. You will see cold, pale, and possible cyanotic extremities. In high output failure, this will result in warmed, flush extremities. Here, if the demand for cardiac output ends up being greater than the ability of the heart to provide, this is when failure will result. Next is pericardial disease. Pericardial disease shows up as an accumulation of fluid in the pericardial space, known as pericardial effusion, or inflammation of the pericardium, known as pericarditis. The pericardium represents the series of membranes that surrounds the heart. It's the sac that the heart is held into. The health threat from pericardial disease occurs when it interferes with the normal pumping action of the heart. Acute pericarditis is a nonspecific inflammatory response to a number of different injuries. These injuries could be of one of 3 different types. It could be intrinsic heart disease, this is the heart itself. It could be disease in adjacent structures, or it could be due to a systemic disorder, some other infection, sometimes even lupus. Different types of effusions can be present with acute pericarditis. A fibrous effusion is when there is a greater amount of fibrin present in the fluid space. The greater the amount of fibrin, the greater the tendency there is to form adhesions and having these membranes stick together. Fibrous effusions often accompany rheumatic fever, myocardial infarction, and immune or viral forms of pericarditis. Usually these are of no clinical significance unless the amount of fibrin is extensive. A purulent effusion is often seen with bacterial and fungal infections. This is a much more serious condition because now the visceral and parietal membranes end up adhering to each other, and the fibrous pericardium can also adhere to adjacent structures. This will then interfere with both diastolic and systolic actions of the ventricles. Clinically, you will have a sudden onset of constant chest pain, which gets worse when one inhales. Pain lessens when the person is sitting or leaning forward. You can also hear a friction rub. This is a scratchy sound heard as the rough fibrin surfaces rub over each other. Heart sounds become diminished if there is a large volume of fluid in the pericardial sac. You can also see cardiac tamponade when there is a very large volume of fluid, and this then interferes with the filling of the ventricles. Chronic pericarditis often arises due to complications in healing of the acute form. One form of chronic pericarditis is chronic constrictive pericarditis. Here you will see a scarred pericardial sac when the fibrosis has been extensive. Now the heart is encased in a non-distensible sac. You can also see stenosis where the veins enter into the atria. This can cause an increase in back pressure to the systemic veins, resulting in an enlargement of the liver and the spleen, and this can also result in a decrease in cardiac output. Chronic constrictive pericarditis is often seen along with tuberculosis. It can also be radiation-induced, especially people receiving radiation therapy for Hodgkin's, lymphoma, or breast cancer. The next disorder is myocarditis. This is an inflammatory change in the myocardium. The myocardium is the thick muscle layer of the heart. Myocarditis is usually acute and mild with complete recovery. But you can also see necrosis of the myocardial cells or heart failure if in more severe cases. Causative agents vary from viruses to bacteria, protozoans, parasites. Could be due to a hypersensitivity reaction, some type of trauma, and many cases are idiopathic. Viral myocarditis is the most common form. This is often seen in infants and young men. The myocardium shows fluid exudate and cellular infiltration. If the person is healthy, this is often just a very mild disease with some pain and weakness. However, if the person is immunosuppressed, it can be more serious and may lead to acute failure. Clinical signs are often variable, and this can take several months to resolve itself, or, again, in severe cases, could lead to chronic heart failure. Endocarditis, this involves the endocardium, which is the lining of the heart as well as the main vessels that enter the heart. This is often referred to as infective endocarditis or bacterial endocarditis. Endocarditis is fatal if it's untreated. Even with treatment, there is between a 30 and 35% mortality rate. The most common causative agents are bacteria, and the cause of death is usually either acute or chronic heart failure. There are two forms of endocarditis, acute and subacute. In both forms, one sees a large infective mass called a vegetation. A vegetation is a thrombus filled with bacteria or other microorganisms. These become dangerous because they tend to break up and then send infectious agents into the blood along with small emboli. Acute infectious endocarditis has a mortality rate of 60 to 80%. Reason being, these bacteria become sheltered in the vegetation. Now the body's own immune system as well as antibiotics are unable to reach them and eliminate them. Signs and symptoms include a changing heart murmur, high fever, chills, petechiae under the nails, splenomegaly, anemia, and hematuria. The two most common causative agents are Staphylococcus aureus and Streptococcus pneumoniae. These bacteria become lodged in the heart valves, and then a thrombus formation will follow. Usually, this is due to a pre-existing infection, not a pre-existing heart condition. So in other words, the person has an infection with either Staph aureus or with Strep pneumoniae. These organisms gain access into to the blood and then become trapped in the heart valves. Death will occur due to emboli or valve dysfunction. Subacute infective endocarditis has a mortality rate of between 5 and 10%. This form does involve a pre-existing heart condition, usually rheumatic heart disease, or it could be due to a congenital defect or valve replacement surgery. The causative agents are usually beta hemolytic forms of Streptococcus or Staphylococcus. Once in the bloodstream, these organisms become trapped in the deformities of the heart and begin to colonize. Symptoms are vague and develop slowly. These may include fever, anemia, weakness, and a murmur. Next, we're going to look at different valvular disorders. These are affecting the four major valves in the heart. These disorders could be either a stenosis, which means a narrowing, or an incompetence, which means the valves do not function properly. Starting with valvular stenosis. Here there is a narrowing of the valve, so the forward flow of blood is restricted. Blood will begin to accumulate upstream behind this restriction, and this is known as congestion. This will result in hypertension in these affected vessels upstream. You will also get heart murmurs. What a murmur is, it's the sound of the blood rushing through this narrow valve, resulting in turbulence. This then creates abnormal sounds that one can hear. Causes of valvular stenosis are varied. They include rheumatic heart disease, endocarditis, congenital malformations, calcification of the valve cusps, tumors, or aneurysms. The first valve is the mitral valve. Mitral stenosis is the most common form of stenosis. Remember, the mitral valve is the valve that separates the left atria from the left ventricle. Mitral stenosis is usually seen in association with other valvular disorders, and it is a very common complication of rheumatic heart disease. What happens with mitral stenosis? You will see impaired filling of the left ventricle. It's very difficult for blood to get through this narrowed valve from the left atrium into the left ventricles. You will see adhesions of the cusp, plus calcification and distortion of scar tissue. This causes dilation and hypertrophy of the left atrium. Because of this chronic filling or increased volume in the left atria, it will dilate due to this volume and hypertrophy, trying to eject this extra volume. You will see elevated left atrial pressure and a decrease in left ventricular flow. The person may experience difficulty swallowing if the enlarged atrium compresses on the esophagus. You will also have a diastolic murmur. The stiff valve will produce snapping sounds when it opens. The other common valve to become stenotic is the aortic valve. This is the valve that separates the left ventricle from the aorta. This may be due to valve damage or obstruction from atherosclerosis, or it could be due to rheumatic scarring of the cusp, or even calcification of the valve. Now what you will see, this results in an increased resistance to ventricular emptying. The left ventricle will now dilate in response and hypertrophy, trying to eliminate this extra volume. As it progresses, the left ventricle will fail. Also, the hypertrophy makes the heart susceptible to ischemia and angina. Remember, you have a larger heart, more muscle tissue, so it has an increased workload and as a result, an increased demand for oxygen. Symptoms include dizziness, fatigue, and pallor. These are all due to the decrease in cardiac output. In severe cases, blood can begin to back up into the lungs, resulting in pulmonary congestion. This will typically be heard as a systolic murmur. The other two valves are the tricuspid valve and the pulmonary valve. Stenosis here is uncommon, but if it does occur, it would produce symptoms of right heart failure. The other type of valvular disorder is insufficiency or incompetence. Now the valve does not prevent reverse flow. The ejected blood regurgitates or leaks back into the upstream chamber. The stroke volume will try to increase by the amount regurgitated in an attempt to maintain cardiac output. However, if it continues to progress, this volume can no longer be cleared, and you often see the ventricle dilate with no increase in wall thickness, and this will result in ventricular failure. First, let's look at the mitral valve. Mitral insufficiency is due to a damaged mitral valve cusp. What could cause this? Remember how the cusps are set up, or the valves, the mitral valve is set up. The valve cusps are attached to chordae tendineae, thin cords, and these chordae tendineae are attached to papillary muscles, which are in the wall of the ventricle. When the ventricle contracts, these papillary muscles contract, which pull on the chordae tendineae, closing the valves. So, a mitral insufficiency could be due to rupturing of the papillary muscles. They will no longer be able to pull on the chordae tendineae to close the valves. This could be the result of a left ventricular infarct. It could be due to rupturing of the chordae tendineae. This is often seen associated with rheumatic heart disease. Or it could be due to the result of bacterial endocarditis. Regardless of the cause, what happens is the valve cusps now fold back and allow reverse flow into the atria. This results in turbulence that is heard as a systolic murmur. This is often referred to as floppy valve syndrome. You will see an increased pressure in the atria and over time blood will begin to back up into the lungs, resulting in congestion and pulmonary hypertension. The atria will also dilate after being chronically stretched, and they won't be able to eject blood properly. You will also see left ventricular hypertrophy. This is an attempt to try to increase the ejection fraction to try and maintain cardiac output. Aortic valve insufficiency. This is often due to either perforated valve cusps due to infection or inflammation, or it could be the result of scar tissue that interferes with proper closing. Now the blood will leak back into the ventricle during diastole, resulting in a diastolic murmur. Symptoms include dizziness, headaches, weakness, fatigue, and signs of left heart failure. Again, the tricuspid and the pulmonary valves, insufficiency here is uncommon. Usually, if it happens, it is seen in combination with other valve defects. If alone, it is usually due to a congenital defect. When it happens, you will see a diastolic murmur and traits of right heart failure. Next, we will look at rheumatic heart disease. This is a potential complication of rheumatic heart failure. This is an inflammatory disease that affects many tissues in the body. Causative agent is usually members of the group A beta hemolytic strep family, particularly those that cause strep throat, such as Streptococcus pyogenes. What happens is the person initially has strep throat about 1 to 4 weeks prior to the symptoms of rheumatic fever. When rheumatic fever affects the heart, it can affect the pericardial sac, the myocardium, the endocardium, or the valves. It can affect any or all of these structures. Usually it involves valvular damage that can lead to congestive heart failure and death. This disease gets its name due to the joint pain that it can also cause. How can strep throat lead to heart disease? When one has strep throat, you will develop antibodies to the streptococcal antigens. Typically, we think of antibodies as being very specific for the antigen they were made against. However, with the strep antibodies, they tend to cross-react both with joint connective tissue and with heart tissue. This represents an autoimmune cross-reaction that can progress rapidly in some people and not at all in others. The disease starts out as a strep infection, but then becomes self-perpetuating with any future strep throats. So any future strep infection will cause further damage to the heart and to the joints. One needs to treat with antibiotics to eliminate the organisms and anti-inflammatory agents to control the symptoms. Pathogenesis. The antibodies that are made to the strep organisms will bind to joint and heart tissue, resulting in an inflammatory response. The attacked cells begin to release histamine and activate kinins. These result in an inflammatory response that attracts macrophages and neutrophils. These cells then cause further damage to the heart and will activate the complement cascade, also resulting in a fever. The heart is affected in about 1/3 of the cases, and it is more likely to happen in the young. What effects do you see on the heart? In acute forms, the valves will become red, thick, and swollen. They will develop wart-like vegetations on the leaflet surfaces of the valves. These are known as varices. With further damage, this can cause valvular stenosis and incompetence. It is the mitral valve that is affected in 50% of the cases. If stenosis of the mitral valve happens, this will cause a heart murmur and pulmonary congestion. Over time, this congestion will lead to chronic heart failure. In incompetence of the mitral valve, you will see regurgitation into the atria. As a result, the left ventricle will hypertrophy in an attempt to compensate for the lower efficiency of pumping, again trying to maintain cardiac output. In other cases of rheumatic heart disease, the aortic semilunar valve can also be damaged. Other valves are not usually affected. Chronic heart failure and death will occur due to damaged valves and the chordae tendineae, due to thrombosis in an enlarged atria, emboli, or possible pulmonary complications. This flowchart shows how a case of strep throat can result in rheumatic heart disease. Next, the biggie, ischemic heart disease. Looking at coronary artery disease, which is often referred to as atherosclerotic heart disease. This is due to the progressive narrowing of the coronary arteries by atherosclerosis. You will see plaques forming in the major coronary vessels. This will result in lumen obstruction, which causes ischemia, chest pain, arrhythmias, and myocardial weakness. With severe obstruction, you will see a decrease in cardiac output and heart failure due to the damaged artery. You will see ischemic damage to the tissues supplied by the ischemic vessel. Treatment, you want to stop the atherosclerotic process, re-establish myocardial flow, control the symptoms, and reduce cardiac workload. Ischemic heart disease is the most common cause of heart disease and death in developed countries. It is due to atherosclerosis of the coronary arteries. Onset may be gradual or sudden depending on the obstruction. In acute ischemia, this is due to coronary thrombosis superimposed on an atherosclerotic plaque. This will result in rapid occlusion of the vessel, causing hypoxic injury and necrosis of the myocardial cells it supplies, resulting in a myocardial infarction. The severity of the injury depends on the size and location of the infarct. Chronic ischemia occurs when atherosclerosis and small non-occlusive thrombi cause slow, progressive narrowing of the arterial lumen. This will allow time for the myocardial cells to adapt to the hypoxia and possibly to develop anastomoses or alternate routes to bypass the blockage. If occlusion continues, necrosis can occur and the damaged cells will be replaced with fibrous tissue. Remember, the heart is unable to regenerate. This makes the myocardium weaker and less extensible. This results in angina pectoris and a gradual decrease in cardiac output. This can lead to chronic heart failure if not corrected. The elements of ischemic heart disease. Angina pectoris. This is chest pain that results from transient myocardial ischemia. It is similar to a myocardial infarction, but less intense. It is felt as pain in the chest wall over the heart and radiating to the left shoulder, arm, or jaw. This can last upwards of several minutes. There are three subsets of angina. The first is typical angina pectoris. This occurs when there is an increased demand on the myocardium that is already oxygen poor. This could be due to an increased stress, increased workload, or a rise in blood pressure. For example, the pain one might experience when trying to climb a flight of stairs. Release will be given when one relaxes, rests, or uses vasodilation therapy. The second subset is Prinzmental variant angina. This is due to coronary arterial spasm in an atherosclerotic artery, and is not caused by an increased workload on the myocardium. It can often occur even while the person is at rest. As a result, the various therapies mentioned above will have no effect. The third form is unstable angina. This progresses rapidly. The frequency and duration of pain increases, and this may be a direct progression to an acute myocardial infarction. Again, the various therapies will have no effect. Sudden cardiac death accounts for half of all of the deaths associated with ischemic heart disease. Now you will see fatal arrhythmias due to the myocardial ischemia. In this condition, you can't assume that there has been any tissue infarction. This may be due instead to one of the following: a vasospasm, occlusion of the coronary vessel by platelet aggregation and thrombosis, or due to an increased exertion. Acute myocardial infarction is when one experiences severe, intense chest pain that radiates to the left shoulder, arm, and jaw. One may also experience sweating, breathlessness, and anxiety. These symptoms are not relieved by rest or by vasodilators. One may also experience nausea, vomiting, and other symptoms of decreased cardiac output. An ECG will be used to assess the location and severity of the infarct as well as the nature of any arrhythmias. Patient needs to be monitored for arrhythmias for several days after the infarct. Blood work will also be done, running assays for various serum enzymes. The two enzymes are creatine kinase and lactate dehydrogenase. The problem, though, is that these two enzymes are released from any injured muscle tissue, not just heart muscle. So an increased level of these two enzymes is not specific for heart damage. But if you see these enzymes elevated, plus there are other symptoms of cardiac distress, this would indicate a myocardial infarction. Consequences of having suffered a myocardial infarction: if one survives, the damaged heart muscle will be destroyed and replaced with scar tissue, and this can result in various other complications, one of which are arrhythmias. Commonly, you will see ventricular fibrillation. Usually this is fatal because it results in a complete lack of synchronization of the myocardial fibers. The cells are active, but they quiver instead of undergoing a forceful rhythmic contraction. The pumping action stops and the cardiac output will decrease. The brain will very quickly become damaged. The ventricular fibrillation can be controlled and prevented with various antiarrhythmic drugs. Defibrillation is what one does when one experiences ventricular fibrillation. This is sending an electric shock to the myocardium. This is used to attempt to depolarize all of the myocardial tissue momentarily in hopes of restoring the normal pumping action of the heart. Another consequence could be cardiogenic shock. This is due to large infarcts and severe arrhythmias that reduce the cardiac output below a level that can adequately supply the tissues. The tissues most vulnerable to hypoxia become compromised, and compensatory mechanisms that kick in will only add to the existing stress. Another complication are thrombi. These are started due to activating factors released from the injured myocardial cells. They will form in the heart at the site of injury or wherever blood pools in the weakly contracting chambers. These are also prone to producing emboli. Another complication is rupture. The necrotic tissue in the heart will be cleared away by phagocytic cells and replaced by scar tissue, but this takes time. One condition you will see is myomalacia cordis. This is when the dead muscle tissue softens, and this will occur for a time period of 7 to 10 days after the infarct. During this time, the wall is subject to rupturing. One area of rupture would be in the ventricular wall, resulting in a ventricular aneurysm. This is due to an infarct in the ventricular wall. When it ruptures, blood now will fill the pericardial sac. This will cause pressure that will prevent the normal filling action of the ventricle and can quickly result in death. An infarct of the interventricular septum can lead to rupture into the right ventricle, leading to a combined ventricular failure. Infarct of the papillary muscles of the left ventricle may cause them to separate from the ventricular wall. Now they begin to flap around, and this can cause mitral insufficiency, which can lead to left heart failure. The prognosis: very few people, less than 10%, experience uncomplicated recovery. These numbers could increase with better management. 20% of the people that experience an myocardial infarction will result in sudden death due to myocardial destruction and fatal arrhythmias. 15% die later from other related problems, such as the ones we just talked about. And about half will result in congestive heart failure. And this is just the flow chart to represent these statistics. Lastly, we will discuss various congenital heart defects. These are due to malformations in the heart or defects in the great vessels. Congenital heart defects are seen in roughly 1% of live births. There are more seen in stillbirths, and these are usually one of the more common causes of prenatal mortality. Congenital heart defects occur either when fetal blood channels remain open or continue after birth, or they could be due to a problem that occurs during the 3rd to 8th week of embryonic development. This is the time period when most internal structures are being formed, so anything that mom is exposed to during this time period could have an effect on the heart development. Many congenital heart defects are hereditary, and others are environmental, such as whatever mom comes in contact with, maternal infections, drug, or alcohol. But roughly 90% are idiopathic. Many congenital heart defects or the malformations may be due to shunts. A shunt, it diverts the blood through different passages. A right to left shunt occurs when flow is diverted from the pulmonary circuit into the systemic circuit. This results in blood being poorly oxygenated because it is now bypassing the lungs. Cyanosis often results. You may also see polycythemia, an increased production or number of red blood cells in an attempt to compensate. A left to right shunt, flow will be diverted from the systemic circuit into the pulmonary circuit. This will result in congestion in the pulmonary vessels. One congenital defect is a ventricular septal defect. This is very common in infants, but rare in adults due to the high rate of infant mortality. Only a very small defects will allow the child to survive. This is often due to failure of the membranous portion of the interventricular septum to close. This will cause blood to be driven from the high-pressure left ventricle into the lower-pressure right ventricle, causing a loud murmur during systole. The results, what happens is you will see right heart overload. You will see an increase in pulmonary congestion because the blood will begin to back up into the lungs. This will result in hypertension in the pulmonary vessels. Dyspnea or difficulty breathing will also be seen due to the increased volume and fluid in the lungs. Fatigue will also be experienced. You will see an increased susceptibility to pulmonary infections, again due to the increased fluid in the lungs. This hypertension of the pulmonary vessels can lead to sclerosis if it persists. This will result in pulmonary resistance. It becomes now very difficult for blood to flow through the pulmonary vessels, and this will cause the shunt to reverse. On the surface, this sounds like a good thing, but if the shunt reverses, you now bypass the lungs, and this will result in cyanosis. Consequences, ultimately, it will lead to right side congestive heart failure. Atrial septal defect is due to either due to an abnormal fusing of the interatrial septum during embryonic development, or it can occur when the foraminal valve does not close. The foraminal valve is an embryonic structure that allows direct route to the left atrium, allowing blood to bypass the non-functioning lungs. Usually these are not diagnosed in childhood because they are often difficult to hear. The atrial septal defects result in blood being shunted from the left atria to the right. This causes an increase in right heart volume and increased flow through the pulmonary valve, causing a systolic murmur. The results, you'll see fatigue, pulmonary congestion, dyspnea, and frequent upper respiratory tract infections. These are often asymptomatic in the young, but as one gets older, you can see pulmonary sclerosis due to the excess circulation through the lungs. As it progresses, the pulmonary arterial pressure increases and the shunt eventually reverses. Again, this is not good because now it will end up bypassing the lungs, resulting in cyanosis, fatigue, and fainting. Over time, it can lead to right heart failure. Another defect is called a patent ductus arteriosus. In the fetus, the ductus arteriosus is a vessel that joins the aorta and the pulmonary artery. It is another shunt that allows blood to bypass the pulmonary circuit and go directly into the systemic circulation, again bypassing the non-functional lungs. After the baby is born and the lungs inflate, pulmonary resistance decreases and flow through the duct will be reversed. Eventually, the duct will become stenotic and close. If it stays open, blood will keep going from the high-pressure aorta into the lower-pressure pulmonary artery and cause a continuous murmur often heard during systole and diastole. What happens is that the child will become very quickly cyanotic. You can see volume overload in the left ventricle, pulmonary congestion and hypertension, again leading to pulmonary sclerosis. If this persists for many years, the increased pulmonary pressure can end up reversing the flow. This is showing the flow, the normal flow, and various fetal conditions, whether you have the foraminal valve stays open or if the ductus arteriosus stays open, showing how the changes in flow pattern and what they can do to both the lungs and to the heart. Next is correction of the aorta. This is a congenital narrowing of the aorta that is primarily seen in males. This results in downstream hypotension and upstream hypertension. There are two forms. The first is preductal or infantile correction. This is when the narrowing occurs proximal to the ductus arteriosus. This results in left ventricular failure due to an increased resistance to flow through the narrowed aorta. You will see symptoms of left heart failure. The ductus arteriosus also remains open because there is not enough back pressure to force it to close. Death will occur at a very young age without surgery. The other form is postductal correction, or the adult form. This is when the narrowing is distal to the left subclavian artery off of the aortic arch. This will result in high pressure in the aortic arch, and this pressure is enough to close the ductus arteriosus. One will experience distal hypotension, and ischemia is partially relieved to the development of collaterals that will bypass this narrowing. As a result, many survive to adulthood. One will see hypertension in the head and upper limbs and hypotension in the lower limbs and abdomen. You will see signs of left heart failure. You can also see aneurysms, thrombosis, or rupturing of cerebral vessels or an aortic aneurysm due to the increased pressure. And this illustrates the two. Preductal, the narrowing is before the aortic arch, and the lower pressure in the arch keeps the ductus arteriosus open. Postductal, okay, it's after the ductus arteriosus. This results in very high pressure in the aortic arch, but that pressure is enough to close off the duct. The last deformity is Tetralogy of Fallot. Tetra means four. There are four abnormalities seen in the heart. There will be a ventricular septal defect, pulmonary stenosis. The aorta will be shifted to the right so it lies over the right and left ventricle, and you will see right ventricular hypertrophy. This last malformation is not a true malformation, but instead occurs as an adaptation. You will get a right to left shunting. Because of the narrow entrance to the pulmonary trunk, blood will be diverted through the septal defect into the left ventricle. Cyanosis usually is seen at birth. This can be helped by surgery. They would insert a temporary bypass vessel between a systemic artery and the pulmonary artery, and then correct the defect when the child is older. Without surgery, death will occur in infancy. And this last picture just compares a normal heart to the various defects that are seen in this condition.